So good morning, everyone. My name is Viraj. I know we need to change the slide. First of all, thanks Akhil for having me here. And my today's job is to talk on the same thing that we've been talking for last 5 years, is impact of sidedness uh, and molecular testing in management of CRC. So since we're talking this for last 5 years, we'll try and make it more interesting and see any new data has emerged and can we have some new take-home messages. So in next 15 minutes, I'll show you what are the molecular differences in the left and right-sided colon cancers and how those molecular differences can impact the sidedness or how the sidedness can impact in choosing our treatment, systemic treatment for stage 4 colorectal cancers. So this was a beautiful work from Salem group back 5 years ago, 2017. And there are two things we can see from this cartoon. One is that there is not one exclusive molecular signature restricted to one side. So there is APC on the right, there is APC on the left, there is TP53 on the left, there is TP53 on the right. So on and so forth. However, the degree of mutations or the frequency or the prevalence changes. So if you see more BRAFs on the right, while more HER2s on the left, more immune-mediated mechanisms, MSI on the right, while MSI is not absent, but very little on the left. Interestingly, there is something called as EGFR receptor ligands, which were once upon a time thought to influence the efficacy of anti-EGFRs. And that you can see that EGFR ligands are less on the right side, while it are more on the left side. And that might be a reason why anti-EGFRs do not work very well as we like on the right-sided cancers. Now, this was another molecular attempt to study colorectal cancer from Guinea and colleagues, and they showed CMS subtypes. And I want you to focus on the two blocks that are down there, the CMS1 and CMS2, and they are enriched for, if you see CMS1, 77% of midguts, and we know midguts is the right-sided colon, and CMS2 is 77% hindgut. So they're enriched for left-sided colon cancer. But if you see, there is not one CMS which is absent in right or left. So this is another cartoon showing the same thing, that the more you go from right to left, the frequency of different CMS or molecular signatures change. And the peak that you see in the center probably represents the transverse colon. Now, sidedness also is prognostic. I think so. It's one of the cheapest prognostic marker we have for colon cancer. But very important things stand out from this picture is the two studies, what I have quoted, the Migid and Shrug, showed that right side stage 4 colon cancer bad. But if you see stage 1 and stage 2 right side colon cancers, they are better than left side stage 1 and stage 2 colon cancer. And probably this is because they are more enriched for MSI high tumors. So sidedness is prognostic, but it depends on stage. So the two quick take-home points are there are significant differences in embryologic origin, right side origins from midgut, and the left side origins from hindgut, and molecular characteristics between left and right side colon cancers. And prognosis by side may differ by the stage at the diagnosis. Now we know how does this impact our choosing of systemic treatment. We know right-sided is bad, irrespective of treatment that you give, whether it's chemo, whether it's anti-EGFR, whether it's bevacizumab. And there is a great meta-analysis which showed whatever you do, if you are stage 4 cancer, unless it's MSI high, your prognosis is very poor. But a very important study by Tribe, and it's an old study, but what I want to share a graph is, if you see the blue curves, they are of left-sided colon cancer treated with doublet plus Bev or triplet plus Bev. And you see there is not much difference. But the dotted orange line is doublet plus Bev in right-sided colon cancer, one of the worst graphs that we have seen. But if you give them triplet plus Bev, you kind of bring them to left-sided colon cancer, suggesting that if you have a bad biology disease or a right-sided disease, you are better off in aggravating or intensifying your treatment to triplet plus bevacizumab rather than doublet plus bev. Now, what about anti-EGFR treatment? So Crystal was the registry trial for cetuximab, and it was a positive study, chemo plus anti-EGFR versus chemo alone. But what is important is I want you to look at the right side two graphs. These are the right-sided colon cancer, and there was absolutely no benefit in either progression-free survival or overall survival by adding cetuximab to chemotherapy. However, all the benefit was taken by the left-sided colon cancers. And the same phenomenon we saw with the PRIME study, again, the registry study of the panitumumab, where if you see the blue lines and the solid lines, the blue and gray, the benefit is there. While the dotted lines, you see they are the right-sided colon cancers. In fact, numerically, panitumumab arm did worse, but nevertheless, the benefit was exclusively restricted to the left side. And then we all had debate about which should be the preferred targeted agent when you start our journey of stage 4 colon cancer. And there were 3 studies with 3 different primary endpoints. And technically, all 3 were negative for their primary endpoints. But they all showed that in post hoc analysis, that if you're on left, anti-EGFR is better. If you're on right, anti-EGFR is worse. And one of the graph is this, which is one of the largest phase 3 data of 1100 study, the CalJB. I wanted to see at the purple line. The purple line is left-sided colon cancer treated with anti-EGFR, and overall survival is 40 months. It's one of the highest that we have ever seen in any phase 3 trial. And the blue line is the right-sided colon cancer treated with cetuximab, OS of only 13 months, one of the worst in any randomized phase 3 trial. Now, if you remember this curves, there are another curves identical to that for the same CalGB studies. And the best patients here were the blue curves. And which were the blue curves? The CMS2 subtypes. And remember, CMS2 was enriched for hindgut. So these are the left-sided tumors who did absolutely well, the same data set of CalGB. And the orange curve were the worst of just 15 months. And who are these orange curves? The CMS1. And we know CMS1 is 80% right-sided. So it's the identical graph, what I have shown here, and this, but this is from the left side, and this is from the sidedness versus the CMS types. So this just confirms our belief that left-sided anti-EGFR is very good, right-sided, you are better off not treating. And the same phenomenon was found in FIRE3. You can see the right side graphs. On the right-sided colon cancer, cetuximab was probably inferior to bevacizumab, while on the left side, 10 months difference in overall survival. And if I compare you in the quick tabular form, if you see the left-sided on the right side, the differences in the survival between anti-EGFR and BEV are statistically significant consistently in all 3 trials. You can see that. But on the other side, on the right side, they are inferior, but it has not reached any statistical significance. So I do believe anti-EGFR has some role in right-sided, but it is modest at best. And then we had Paradigm to prove what we've been doing retrospective so far. It was presented last year as MGI. I saw we discussed this last month, and this was the primary endpoint was OS in the left-sided population, anti-EGFR versus bevacizumab plus chemotherapy. Primary endpoint was positive. There was a 3.4 months difference in survival. However, there were questions asked that the hazard ratio was just 0.99, the confidence interval. It could have lost. And the PFS was identical and the curves were crossing each other. So all these questions were asked. Nevertheless, this just proved our belief that anti-EGFR are better than BEV in left-sided disease. So if I have to draw a perfect candidate, so tomorrow if I have a colon cancer, which is the perfect candidate where I would jump on and use anti-EGFR? So we, in lung cancer, we use positive biomarkers. They were talking about EGFRs and ROS and ALK1s. Here we talk about when these are mutually exclusive. So around 60 to 65% are patients gone. Now, if you see again right-sided who are wild type, which add another about 5 to 10%, we will not give anti-EGFR. So probably it's 1 in 4 or 1 in 5 patients that come in your practice are ideal candidate for anti-EGFR, but I say they are the true winners. That's a true precision oncology. Usually they work very well if you select patients like that. So take home from these points are patients with right-sided MCRC do not seem to benefit from treatment with anti-EGFR in first-line setting, regardless of RAS or RAS or RAF status. Now, does sidedness have any impact in second line and beyond? So this we talk about first line. People say right-sided if you start with BEV. Can you use anti-EGFR in second line? So we have some data. Of course, it's controversial data. But there is data of panitumumab, 408 and 181. These are the two second-line studies. Now, the numbers were very small, but you see the right side benefit of panitumumab in especially these two series was not so great. In fact, if you see numerically, it was same 1.5 versus 1.7. So, but because of small numbers, there is no strong endorsement that you should not use. And we have cetuximab data for third line, where it was the study which showed us that you should do KRAS mutation for negatively selecting cetuximab. And what you see is the two graphs right-sided, absolutely no difference in PFS compared to best supportive care with cetuximab, while on left side, the benefit was 10 months versus 4.8 months. So what does the guidelines say? Now, the guidelines, unfortunately, are divided. The ESMO and NCCN are divided in this manner. Now, ESMO says on the left side, you give chemo plus doublet chemo plus anti-EGFR is the treatment of choice, while NCCN has left it open. NCCN says you can use anti-EGFR, you can use BEV. And I think so it's important for our country where anti-EGFRs are expensive. We take comfort in NCCN because we are allowed to use BEV on the left side as well. So I think so we like NCCN because of that, but ESMO categorically says you use anti-EGFR. Now on the right side, again, they are controversial. Cytotoxic triplet plus BEV, that's what ESMO says, and cytotoxic doublet plus anti-EGFR. Now we just saw on the right side, anti-EGFR is not very good. So, but here they are recommending if somebody is shooting for a response and downstaging, one may consider doing doublet plus anti-EGFR. That is ESMO's recommendation. But what is NCCN's recommendation? No anti-EGFR on the first line for the right-sided colon cancer, and potentially not in any line. So if you see the text in the NCCN, they say that the panel believes that anti-EGFR has modest activity on the right side, even in subsequent lines. However, they do not have enough evidence to categorically say no and will allow you to use it, but they are reserving their judgment for later. So you see how NCCN and ESMO have divided their judgment for BEV and anti-EGFR. Even after 5 years, they cannot have a unanimous decision. So to conclude, there are significant differences in embryologic origins and molecular signatures between left and right-sided colon cancers, and molecular differences between two sites exist on a continuum with neither showing mutually exclusive signatures. Anti-EGFR agents should not be used in first-line therapy for right-sided colon cancer. I know Dr. Ramesh Vora will grill me on this, irrespective of molecular profiling. However, they must be preferred targeted therapy for left-sided all RAS wild-type colon cancers. Data is evolving. I think some few of my slides are not seen. Let me show like that. Okay. All right.